Welcome back from lunch. Our next speaker is John Krystal, the Robert McNeil Professor of Translational Research and Professor of Psychiatry, of Neuroscience and Psychology, Chair of Psychiatry, and Physician-in-Chief of Psychiatry at Yale-New Haven Hospital. John.
It's really a pleasure to be here, and thank you for inviting me to join. I've really enjoyed the talk so far today, and hopefully you'll like this one. So I'm going to be talking about the neurobiology of the antidepressant effects of ketamine, what we've learned about this drug. This is a drug that I've studied since the late 1980s, so a long time, and hopefully you'll see some links to the neurobiology of depression, which we've also been studying in parallel. Before I begin, I want to acknowledge my financial interests. Patents in which I'm a co-inventor were licensed to Janssen related to the development of esketamine. I also have spun off a company called Freedom Biosciences, which is trying to develop next generation alternatives to ketamine and the psychedelics, and consult to a variety of companies. And also that the work that I'm going to be talking about today is really teamwork. A lot of people have contributed to the work, and I particularly want to acknowledge Dennis Charney, who was my mentor way back when, and we worked together on the initial ketamine study, and Ron Duman, the late Ron Duman, who passed away far too young and contributed to what we understand about the neurobiology of ketamine effects. So you've already heard that antidepressant drugs are great for many people, but too few people respond to them. When they respond, it takes a long time. In the STAR-D trial, it was 2 months about on average until remission, if you were lucky enough to achieve remission. And what happens during treatment is that people get discouraged, they stop taking the medication, and that really further undermines the effectiveness of depression treatment. And what's often not appreciated is that clinical response to antidepressants, particularly if you have the sort of depression that is less responsive to medications, can be quite unstable. So in clinical practice, it would not be that uncommon that I would spend a year working with a patient, trying different medications and different combinations to get them better. And then within a few months of achieving a clinical response, they would relapse. And that's terribly, terribly discouraging for everybody involved. So I'm going to talk a little bit about ketamine as a treatment. Then I'll talk about depression in the glutamate synapse, talking a little bit then about ketamine efficacy and how we might enhance it. So this was the first randomized trial with ketamine. It was published in 2000, a small number of patients. But in these data, you see the essence of what we've learned with other treatments. First, that there are transient ketamine effects, both euphoric and psychotogenic or dissociative, and those effects go away within about 2 hours. But what you can see is that at about 4 or 5 hours, after a single dose of ketamine, patients in this study began to feel a little bit better, a little bit lighter. And by 24 hours, about half of the patients had remitted. In other words, they didn't feel just a little bit less depressed, but they felt like they were back to themselves. So to try to give you a feel for what that's like for patients, I'm going to show you a little video from one of the patients treated at Yale. If we could run the video.
I've been in treatment pretty consistently since I was in middle school. I had a combination of different styles of therapy as well as different medications, and my functioning was pretty high, but I tended to still really struggle with these feelings of just profound aloneness and despair. And about 3 years ago, I kind of slipped into what I would consider a very severe depression. I'm receiving intravenous ketamine, and The day after I received my first treatment, I felt like myself. But what was strange, it was like immediate. The next day I woke up and I felt I could internalize good things about myself. I could feel positive feelings. I could feel feelings in general. The gratitude I have for this treatment. And so thankful I live in an area where there's such innovation happening. I didn't even know this was possible.
The commercial at the end, but you get the feeling that if you're fortunate to be one of the people who has this kind of rapid response to ketamine, it can be really transformative and really strikingly rapid and profound. So ketamine and S-ketamine treatment both follow a certain kind of pattern. They're dosed in a very narrow dose range, and they're started twice a week, and then gradually the frequency of treatment tapers over time. So about 75% of patients eventually achieve treatment with one dose every 2 weeks. And about 50% of patients in our clinic get to about once every 3 weeks. And so it's 2 hours out of your day. You don't usually return to work after getting a ketamine treatment if you have it during the workday. But it is overall limits the side effects and risks predominantly just to that session, and the rest of your time you're not burdened by medications. One of the unappreciated or underappreciated effects of these drugs is that when added to antidepressant medications, they are much more effective in preventing relapse to depression than standard treatments. So in our secondary analysis of duloxetine and fluoxetine data, if you compare drug to placebo, the protective effect is about 12% of drug over placebo in terms of preventing relapse over 6 months to a year. Here, if you're comparing ketamine plus S-ketamine plus antidepressant medications versus a new antidepressant, you see that the difference is about double that, about 25% difference. And the relapse rate in the S-ketamine group is only 25.8 or 9%, which is really a tremendous protective effect for patients who have treatment-resistant symptoms. Now, over the past year, 2 new studies help us to better understand the kind of impact of ketamine and S-ketamine. The first study, which was by Reif et al., which appeared in the New England Journal of Medicine, showed that the odds ratio of remitting on S-ketamine compared to what is the kind of standard clinical practice for treatment-resistant depression, which is adding an adjunctive antipsychotic medication, that odds ratio is about 2, meaning that this S-ketamine is the most effective strategy that we have for managing treatment-resistant symptoms, medication strategy, excuse me. The second major study was a comparison of ketamine to electroconvulsive therapy. This is a study led by Amit Anand here in Boston. And what this consortium found was that ketamine was not inferior statistically to the efficacy of electroconvulsive therapy, where you're putting a person under general anesthesia and putting an electrical charge into their brain and producing a generalized seizure. In fact, numerically, if you look at the data closely, you can see that ketamine is actually doing a little bit better than ECT, but this was a non-inferiority study design, and so the only claim is that you would say it was non-inferior to ECT. So together, these give you a feel for just how profoundly effective ketamine and S-ketamine are, in that most people would have said that electroconvulsive therapy is the gold standard for treatment-resistant symptoms of depression. We now have long-term data with S-ketamine that has been collected by Johnson & Johnson and compared to historical data that they have access to. Long-term treatment in over 1,000 patients, by long-term I mean on average 42 months of treatment, produced a 10-fold reduction in suicide attempts compared to standard treatment, a greater than 5-fold reduction in death by suicide compared to standard medication treatment, and a greater than 3-fold reduction in all-cause mortality. And the way that these drugs reduce all-cause mortality is that depression turns out to be a whole body disease. And if you're depressed and you have cardiac disease, the chances of dying from cardiac disease are worsened, respiratory disease, renal disease, cerebral vascular disease, et cetera, et cetera. And it seems that even compared to standard antidepressant treatments, which affect these various outcomes, that S-ketamine treatment is better able to reduce the aggravation of these other medical conditions, presumably by affecting inflammation and other processes in the body. Ketamine is still being tested for a variety of other conditions, all of which are still in early stages of evaluation, but you can see that there are a wide range of conditions where it may turn out that ketamine or S-ketamine may have additional clinical applications. So let's talk a little bit about the glutamate synapse. And I appreciate that this is extraordinarily rudimentary for 99% of this audience, but for that 1%, let me just introduce you to the glutamate synapse. Glutamate constitutes the vast majority of neurons in the brain, and probably something like 80 or 90% of the synapses in the cerebral cortex. It's an excitatory transmitter when glutamate binds to receptors that mediate excitation, which includes NMDA, AMPA, kainate, and some metabotropic glutamate receptors. And so I want you to remember AMPA, because it's different than the NMDA receptor, which is the target that is blocked by ketamine and S-ketamine. So over the last 15 or 20 years or so, my colleagues and I have tried to study glutamate synaptic function in vivo in depression using a variety of neuroimaging techniques. So the first finding that we have, which was led by my colleague Irina Esterlis, uses a tracer called UCBJ, which binds to a protein called SV2A. SV2A is a marker that we can use to count the density of synapses in the brain. And so what you see in severe depression is a reduction in synaptic density. And that reduction in synaptic density is associated with alterations in cortical functional connectivity that we can measure in these people with functional magnetic resonance imaging. Another and more recent and more preliminary finding comes out of studies that have been, where we've used a technique called carbon-13 magnetic resonance spectroscopy, and where we can measure something that may be a little bit analogous to the basic scientists to LTD. And we're measuring something analogous to synaptic strength. So the idea behind this measurement is normally when a molecule of glutamate is released, it triggers a certain amount of metabolic activity in the brain. And we can quantify the rate of glutamate release, and we can quantify the metabolic response. And what we find in depression, or at least depressed patients comorbid with PTSD, is that when a molecule of glutamate is released, a smaller cerebral metabolic response is generated. So reduced tricarboxylic acid cycle per molecule of glutamate released, which we measure as something called V cycle. A third abnormality, which I'm really not going to have much time to talk about today, but which has been the focus of research by a number of investigators, particularly Lisa Monteggi in the group and Ege Cavallali in the group at Vanderbilt, is the idea of impaired glutamate homeostasis, either because of increased glutamate release or impaired glia function. When glutamate is released, it doesn't get taken up and it hangs around more, and that's not good for the brain. So why do we care about synaptic efficacy as well as synaptic density? One is that we need this synaptic efficacy and density for networks to communicate with good signal-to-noise properties, and also these properties underlie neuroplasticity in the brain. If we think at a more macro scale, what we're seeing is evidence of compromise, mechanisms that compromise top-down control of emotion, reward function, behavioral flexibility, and resilience, all aspects of that we would consider to be relevant to depression. So how does ketamine do this? What you're looking at here is a two-photon study done in the laboratory of George Agajanian, who sadly passed away this year, and Ron Duman in their classic 2010 paper in Science. What you're looking at is a dendrite, which is an input into a nerve cell, and you can see that a normal dendrite has lots of these little blebs sticking out. These are called dendritic spines, and they are sites where glutamate synapses are made. They are the postsynaptic sites, you might say. If you stress an animal, then you can see that there is a reduction in the density of these blebs, these dendritic spines, which tells us there's a reduction in the number of synapses. And in this stressed rodent, 24 hours after a single dose of ketamine, you see restoration of the dendritic spine populations. And the elegant work of Connor Liston has told us that it's not willy-nilly spine growth, but rather a regrowing of spines at sites that previously had spines. So how does this happen? The idea that comes out of the work of Ron and George's research is that ketamine, in particular, is binding to NMDA glutamate receptors that activate GABA inhibitory neurons. And there's some new data that helps us to understand why that is a particular property for ketamine at subanesthetic doses. As a result of reduced GABA release, reduced inhibition, there's an increase in glutamate released. One of the consequences of that increase in glutamate release is that there is a restoration of synaptic efficacy. You can see an increase in AMPA receptor subunits, and functionally those synapses show increased efficacy. It's not entirely clear whether this response is triggered by stimulating NMDA receptors or AMPA receptors, yet maybe both, but that is one of the earliest changes that happens. And then downstream, as a consequence of elevating the intracellular concentration of brain-derived neurotrophic factor, or BDNF, and local release of that BDNF, there's a stimulation of TrkB receptors, which activates a signaling chain, including the activation of mTORC, or it's a molecular target of rapamycin. mTORC is a key node in regulating protein synthesis, and its activation recruits the protein synthesis necessary to generate or regrow the dendritic spines and reestablish synapses. So we have a putative pathway based on reversing ketamine's ability to reverse the effects of stress in animals. And so let's look at how this holds up in translational research. The first direction we wanted to pursue was to see if we could detect an effect of ketamine stimulating cortical glutamate release in people. And the first technique we used was, again, this carbon-13 magnetic resonance spectroscopy. And with these data, we could measure directly an increase in the rate of conversion of glutamate to glutamine which is this stoichiometrically related outcome, which enables us to infer the rate of glutamate release. The second way we looked at this question used positron emission tomography. In particular, a ligand that binds to the metabotropic glutamate receptor type 5. And this ligand, when you give a dose of ketamine to a patient with depression, you see a reduction in that ligand binding to the mGluR5 receptor. And that is indicative of local glutamate release. What's important about this finding is that in these patients, the degree of displacement correlated with the magnitude of the antidepressant response. And then there was a very interesting study out of Boris Heifetz's group at Stanford where he put patients under general anesthesia. And under general anesthesia, ketamine does not cause glutamate release. And so what they found in these anesthetized patients was that the antidepressant effects of ketamine were blocked. So together, these studies support the idea that the disinhibition of glutamate release by ketamine is integral to its ability to generate an antidepressant response. What about the regrowth of synapses? Now, you may remember that I said that there is a PET tracer, UCBJ, which binds to a protein that we can use to tag synapses. And so using this approach, we conducted a pilot study, again led by Irina Esterlis. And in this study, we studied 3 groups of people: healthy subjects in gray, patients with relatively milder depression who did not have deficits in synaptic density, and in red, a group of depressed patients who did have synaptic density deficits before their treatment with ketamine. And what you can see is that ketamine does not produce consistent increases in synaptic density in the healthy group or in the depressed patients without synaptic deficits, but it produces a consistent increase in this group of depressed patients. It's a small increase, but a relatively consistent one. And in the patients who had synaptic deficits. And this is consistent with the idea coming from Connor's work that it doesn't just grow synapses, it restores synaptic connectivity. One of the interesting signals from that study is that the patients who have the greatest reduction in depression severity, in other words, to the left on the x-axis, show the greatest, I have the opposite. The patients who show the greatest increase in synaptic density have the greatest reduction in depression severity. So in the red group, this relationship is really relevant. And if you don't have synaptic deficits, there's really no clear relationship. So here, you might say, I've suggested that there's at least 2 things going on, right? There's the people whose improvement is dependent on regrowth of dendritic spines and synaptic connectivity. And there's a group of people who's showing some improvement in depression, but they're not getting spine growth. So that leads us to the potential importance of increases in synaptic efficacy as a contributing mechanism. And this is a study that was done by Carlos Zarati's group at the intramural program at the National Institute of Mental Health. And what you see is that in this group, healthy subjects, there's no difference pre and post ketamine in the magnitude of sensory evoked potentials measured with magnetoencephalography. That's true in healthy subjects. That's true in depressed patients who fail to respond to ketamine. But in depressed patients who do show an antidepressant response to ketamine, you see an increase in the magnitude of the sensory evoked potential consistent with an increase in synaptic efficacy. Now, ketamine isn't the only drug that enhances glutamate release. And a class of medications that you have heard a lot about lately, the psychedelic drugs, rather than disinhibiting glutamate release the way that ketamine seems to, directly produce glutamate increases by stimulating release at the level of thalamocortical terminals and directly stimulating the proximal dendrites of cortical pyramidal neurons. In other words, activating the neurons directly in the brain. So a little bit different than what ketamine is doing, but producing some convergent effects that produce some similar downstream consequences like spine growth and rapid clinical antidepressant effects. So the last part of my presentation is about some strategies that we're evolving to enhance ketamine efficacy. So for example, behavioral interventions. So like the first procedure, one of the first procedures in psychiatry, maybe it wasn't the first one, was psychotherapy. So how could you interact ketamine with psychotherapy? Well, there are two ways to think about it. First, there's an idea of taking advantage of the fact that while ketamine is in your body, it reduces neuroplasticity. And it does that by blocking the NMDA glutamate receptor, which is an important node for inducing neuroplasticity in the brain. And the clever idea here is that every time you reactivate a memory, that memory and the associations to that memory are in a labile state. You can strengthen the associations, you can weaken the associations. So if you have maladaptive memories, like memories of a psychological trauma or memories of your favorite drug of abuse, when you reactivate those memories and then give ketamine, it looks like you can weaken those associations, those maladaptive associations. However, 24 hours after the dose of ketamine is given, and when you increase synaptic efficacy and synaptic density, that's a good time to use traditional learning-based therapies, extinction-based therapies, cognitive behavioral therapy, perhaps even psychoanalysis. And I'm going to show you illustrations of both of these points. This is a study led by my colleague Ilan Harpaz-Rotem and his wife Ifat Levy in our group, and what you see is the impact of reactivating a trauma memory and then giving ketamine or midazolam, a comparison drug that's also sedating and anxiolytic. And what we're looking at on the left is not that. What we're looking at on the left, this is the group, we're looking at the extent of amygdala activation as they are exposed to reminders of their trauma. And here, midazolam has not attenuated the amygdala activation. But this procedure of reactivating the trauma memory and then giving ketamine has produced a long-lasting reduction in the amygdala activation in response to that trauma memory. And this is paralleled by galvanic skin response, which is, you might say, a physiologic indication of how stressed people are in reviewing their trauma memories. And here is, in contrast, this is data from Sam Wilkinson, another colleague at Yale, that where a single dose of ketamine is given, and then people are just returned to their treatment as usual or start cognitive behavioral therapy. And you can see that the impact of this dose of ketamine is sustained and maybe augmented by adding cognitive behavioral therapy in this window of time when neuroplasticity is presumed to be increased. Now, I told you that dendritic spines weren't the whole story, but they are an important part of the story. And Connor Liston, for example, showed that the antidepressant response is initiated before the dendritic spines grow. But if you prevent the growth of the dendritic spines, then the antidepressant effect of ketamine is very transient, not sustained at all. And so that work is very interesting in light of finding from Alex Kwan, who was at Yale and now is at Cornell. And what Alex's group showed was that by about day 5 to 10, by that time, animals have lost most of the dendritic spines that have regrown. And this is about the duration of the antidepressant effects of a single dose of ketamine in humans. So these data, together with what I've told you, raise the possibility that dendritic spine loss is related to the rate of losing the antidepressant effects of ketamine. And if there were ways to sustain or protect these dendritic spines, that perhaps these newly regrown spines would last longer and the antidepressant effects of ketamine would last longer. This is a really interesting framework to look at the data that I'm going to show you now, which is a study that we conducted where we gave people a really low dose of rapamycin, the drug that inhibits mTOR, before we gave them their ketamine. This is a crossover design in 20 patients who had failed at least one prior episode of antidepressant treatment and were now symptomatic with depression. So everybody is their own control. They got ketamine in two different sessions, and one session they got placebo, the session they got rapamycin, and they couldn't tell the difference. They couldn't tell what they got. And what you see, perhaps first and foremost, is just how good an antidepressant is. Nearly 80% of this group achieved a clinical response within 24 hours of their first dose, regardless of whether or not they got rapamycin. There was a hint of a benefit of rapamycin in terms of enhancing the remission rate, but that's not statistically significant. What is really interesting to us is this data at 2 weeks. So at 2 weeks, in this group of people, when they got ketamine by itself, there were only 13% still responders at 2 weeks. But the group that got pretreatment with rapamycin, when they got that pretreatment, 41% were still responders at 2 weeks. And it raised the possibility that rapamycin could extend the duration of the antidepressant effects of ketamine. And that might mean that rapamycin is protecting those regrown dendritic spines. And we know that one of the things that is involved in the protection or elimination of these dendritic spines or these synapses are the role of microglia, which are involved in inflammation. And rapamycin can repolarize microglia, shifting them from pro-inflammatory synapse-gobbling microglia to neurotrophic synapse-protecting microglia. And one reason that we think that this synaptic protecting action of microglia is important to the antidepressant effects is because when you give a microglial toxin, CSF1R antagonist, and wipe out all the microglia in the brain, you eliminate or prevent the antidepressant effects of ketamine in animals. So we think there are potentially two ways we can think of enhancing the ketamine response. One is through behavioral enrichment in the two ways that I described, and the other one is to protect these regrown synapses. Potentially, mTORC inhibition might be one strategy to think about in that direction. So what we've seen is a renaissance in novel mechanisms. We have psychedelics, we have ketamine, we have MDMA coming out. We have a number of treatments that may address the disruption in synaptic homeostasis. I didn't have time to talk about it, but drugs like brexanolone and zuranolone, which have been improved for postpartum depression, as well as a number of novel mechanisms such as Kv7 agonism and some other mechanisms coming, may be strategies for compensating for disruption in glutamate homeostasis. The psychedelics are coming very soon. Probably psilocybin is under review by the FDA, also rapidly acting, also glutamate release inhibiting, also spine regrowing. So that's very exciting. Implementation starts to be a challenge with some of these new treatments. Psilocybin, for example, lasts 6 to 8 hours. It's a long day of treatment. It's very expensive to provide people with the supports that they need for psilocybin treatment. And psilocybin, to a much greater extent than ketamine, is very activating. So people can be flooded or overwhelmed by the content that they experience during psilocybin treatment, need a lot of support and a lot of debriefing. Some people will have suicide ideation triggered by the psilocybin exposure, and they obviously need to be protected in that way. But that creates interest in non-hallucinogenic psychedelics. And there are a variety of strategies that that are being studied by various groups, including our own. And these may be, we don't know yet whether any of them are going to be as effective as psychedelic drugs, but they are maybe more feasible strategies to implement at scale. So in closing, how does ketamine work? Restoring synaptic efficacy, restoring synaptic density, restoring or compensating for disruption in glutamate homeostasis, and modulating experience-dependent plasticity. These are new kind of cornerstones in the way that we think about depression, the biology of depression and depression treatments, and I think will be themes that will run through this next generation of novel antidepressants. So, thank you very much.
Okay. It's on, yeah. That was so great. Amazing. To what extent do we know whether the existing antidepressants interact with these same pathways? Is this completely independent of what we think is going on with some of the existing medications? And one small question was, you showed the synaptic kind of decay of the restored synapses, but that looked like it was going down faster than what you had suggested. The effects of ketamine might be actually more long-lasting than the 10 days or whatever it took to. Or am I just seeing that wrong?
So remember, at 2 weeks, the persistence of response was 13%. So I think it's pretty consistent with the time course of the antidepressant effects. So obviously, the initial targets of standard SSRIs and ketamine are different, but there are some convergences. It's pretty downstream signaling pathways. Certainly, elevations in BDNF can be seen with long-term regular antidepressant treatment. There is one exception, and that's dizipramine. For those of us old enough to have prescribed dizipramine. And that is that dizipramine blocks the NR2B subunit of the NMDA glutamate receptor. And it's really funny for me to think about this because one of my mentors, teachers when I was a resident, is a guy named Craig Nelson, who's now at UCSF. And Craig was doing rapid bolus loading with intravenous dizipramine infusions in the 80s as a way to, and his claim was, if you bolus load dizipramine and get the blood level up high, intravenous with intravenous infusion of dizipramine, then you have a more rapid antidepressant response. And very likely, without appreciating what he was doing, he was, giving a ketamine-like dose of dizipramine.
I just had a quick question related to actually what Dr. Smoller had mentioned. So if you look at your all-cause, the drop in all-cause mortality, that's intriguing, and you've attributed to the immune effect, perhaps. Have you looked at the white cell counts in those patients pre and post to see as a crude marker? You have a test population there for that observation?
So I haven't looked at white cell counts, but what a number of groups have done, particularly Carlos Serrati, who's looked at this in a variety of ways, but a couple of other groups have as well, are reductions in plasma cytokine levels in CRP. And you do see both peripheral evidence of anti-inflammatory effects. In animals, you can see evidence of central anti-inflammatory changes as well in brains.
Thanks for your talk. The work of Professor Eero Castren found that SSRIs and ketamine each directly bind to the protein TRKB.
Yeah.
And psilocybin also binds slightly differently, but with 100 times the affinity. Do you think those effects might be important for the MOA of ketamine? Or?
Yeah. So I think that the psychedelic effects of the various, so Eero, I know Eero very well. He actually did a fellowship in Ron Duman's laboratory that I was acknowledging earlier. These are really interesting data, and it's too early for me to say how important it is, but it's certainly remarkably interesting. And I just point out this protein, TrkB or TRKB, is the receptor for BDNF that's released locally. So it's very, what he's essentially saying is that there's one way that ketamine and these other drugs are raising BDNF and increasing stimulation of the receptor sort of as an indirect effect. And maybe there's, on top of that, an additional direct effect of these drugs that augments the ability or activation of TrkB receptors. So I think it's possible. It'd be really cool if it is. And I would add one other thing, that one of the interesting drugs, I've kind of lost track of where it is, but it was being developed by a company called Navitor, increases the effectiveness of TrkB in activating the downstream signal cascade. So it's not targeting BDNF, it's not targeting glutamate, it's not targeting serotonin, it's targeting the intracellular mechanisms through which TrkB activation activates the cascade. And so I think this cascade is really important for effects. One other target that's relevant to this circuitry that I didn't mention is the AMPA glutamate receptor itself. And there was new data released this week about a drug that's called an ampakine that facilitates the activation of the AMPA glutamate receptor directly and seems to produce antidepressant effects as well.
We have time for one or two more.
There's some questions in the dark side of the room.
Dr. Brown.
It's hard to see you all the way over there.
Dr. Brown has a question.
Well, I suspect that the array of circuits that are affected by ketamine is much broader than the circuit changes that are relevant to the antidepressant effects of ketamine. And so trying to sort out that difference has been sort of one of the directions that this is going. I think there are certain nodes that we're pretty confident are relevant. So for example, in animals, if you optogenetically activate the infralimbic cortex, or directly administer ketamine into the infralimbic cortex, you get the full antidepressant effects in animals. That has been claimed for hippocampus, but I am less confident of those data as well. So I would say that it's very likely that there's a network that needs to be activated and can be activated for multiple nodes. And it's quite likely that parallel processes are happening at multiple nodes in that network produced by ketamine, because ketamine has this effect on these particular populations, like the somatostatin interneurons, has this effect kind of throughout the circuit. So I think there are local effects. I think the network response is important, and probably some interplay that we don't yet fully understand about that, how that works. Maybe from your work, we'll figure it out.
Are there negative side effects of ketamine treatment ever?
ever threw me for a loop. So subjectively, the negative effects of ketamine are a little bit like if there was a short-acting version of alcohol and you drank a ton of alcohol. Okay? So you can get a little nauseous, you might vomit, you might get a headache, you might, your blood pressure might go up a little bit, and all those effects go away before you're discharged from the lab. They last an hour to 2 hours. Those aren't really the things that worry me, though. There's also dissociative symptoms, and most people tolerate that just fine. You tell them, you know, your arms are going to grow a little longer for about 20 minutes, 30 minutes, and then they'll go back to the way it was. You may feel like your body organs are replaced with machine parts. Don't worry about it. It's just gonna go back to the way it was before. And people, you know, sometimes have to remind them. They say, "What's going on? You see, remember that thing about the machine parts? That's what's going on." "Oh yeah, okay." And then they can pretty much handle that. Two things. One is that some people, mostly in my experience, people who have a history of schizophrenia or psychotic vulnerability, they can get more upset and distressed during the ketamine infusion. So we usually exclude those people from getting ketamine as a treatment. The thing that really scares me is the abuse liability of ketamine. So there are some doctors out there that are prescribing, you know, a month's worth of daily ketamine in a big bottle for people to use whenever they feel like it. And there are two parts to that really set people up for developing ketamine addiction, which is a terrible problem. The first is they tend to take doses that are too low to be effective. And because they're in a lot of distress and they're taking doses that are too low to be effective, they're taking them more often. So like when they're stressed out, they have a big meeting, they're going into you know, a social event where they feel very anxious, something bad just happened in their day. You know, so what happens for some of these people who get a lot of ketamine to take home is that instead of taking one dose every 2 weeks, they take 6 to 8 doses a day. So I've seen people who've developed that kind of habit. And that's the thing that I worry a lot about, which is the abuse liability of ketamine and esketamine. And that's one of the reasons that Johnson & Johnson kept the development of esketamine limited to clinic, and the FDA, similarly, in the REMS for esketamine, limited it to clinic settings. You know, it's nominally for these other side effects, but the real risk is probably addiction.
Thank you so much.
Thanks.